Hello, this is another DAROGA lecture, and we are spending two parts on postpartum hemorrhage, a big important topic. The overview of this lecture: first I will start with the introduction, explaining the pathophysiology of hemostasis postpartum, the normal situation. Then we'll look around the world and look at the impressive mortality figures, especially in the low resource countries. Of course, we define PPH, and then we will follow with a number of risk factors and what can we do to reduce the risk that the lady will have postpartum hemorrhage. Eventually, we will start the management regardless of the cause, and that means resuscitation, Dr. ABC, without delay. In the second part of the postpartum hemorrhage lectures, I will pay attention to the specific PPH management after we performed Dr. ABC, and we will discuss that we have four areas of interest: the tone of the uterus or the lack thereof, tears or trauma, tissue, and thrombin. And as always, we will finish with a summary. Yeah, you can see here a picture of myself and Zen Master in Chief Jimmy enjoying a quiet moment, and you can see that Jimmy is dressed in red, completely appropriate to the occasion of postpartum hemorrhage. The primary hemostatic mechanism after delivery is the contraction of the myometrium. We can see here a picture of where this is the uterine wall, the myometrium. The yellow color is the endometrium, where we can see the spiral arteries, and it's thanks to the, you could say, these blood vessels supplying the placental bed. They pass through the lattice work of the uterine muscle, and the myometrium contracting is the main driving force for one, the placenta separation, and two, hemostasis through the constriction of these blood vessels. So this is also described as physiological sutures or living ligatures. In addition, of course, we will have clotting factors to make sure that the blood control, the blood loss after a delivery is limited. Definitions. Primary PPH is when a woman has more than 5 milliliters of blood loss after a vaginal birth, or more than 1,000 milliliters following a lower segment cesarean section in the first 24 hours after delivery. Here on the right hand side we see a few pictures, and it's not very clear, but what it brings across is that the estimation of blood loss is a very difficult one. Here we see just the different amount of blood, 30 milliliters up to 3 liters, when we can see blood on the floor. We tend to underestimate, so if possible try to weigh various pads, or try to weigh and try to quantify the blood loss as reliably as possible, but it's hard. Sobering fact about maternal mortality. Each year more than 500,000 women around the world die due to pregnancy, to the direct cause of pregnancy. That means one woman in every 4 minutes. And 99% of those maternal deaths take place in low resource countries. So the risk that a mother dies as a direct cause of maternal death in pregnancy or postnatally is 100 times higher in low resource countries compared to the richer countries. Obstetric hemorrhage is the leading cause. Here I show an overview of the world map, and we can see the darker areas, particularly here in Africa, where we can see a very much higher maternal mortality rate compared to countries such as United States and Canada, Europe, and for instance Australia and New Zealand. So astounding differences, and it has to do just with the availability of simple an experienced midwife and obstetrician quite often makes a difference. And the availability of some drugs and maybe IV fluids and blood products. Here we see a pie chart which makes clear that the vast majority of maternal death, here the 35%, are due to maternal hemorrhage, 18% due to preeclampsia, hypertension, sepsis, abortion, and other direct causes. So hemorrhage is the big ticket item here. I took this from a nice video for low resource countries, and it explains very well how to manage bleeding after birth if there's no care available within 4 hours. And this is something we find hard to comprehend if we live in well-resourced countries. This video explains very well what to do, and the only cheap drug available is misoprostol. Risk factors. I collated 2 slides with risk factors. Here we see one slide derived from a publication of Shiner in 2005, where a retained placenta increases the odds ratio by 3.5. Failure to progress in the second stage 3.4, a placenta accreta 3.3, lacerations 2.4, instrumental vaginal delivery 2.3, an LGA baby 1.9, hypertensive disorders 1.7, induction of labor 1.4, and augmentin of labor with oxytocin 1.4. So this is one source. Here's another source of risk factors where multiparity gives a higher risk, placenta previa gives a higher risk, and for the intrapartum postpartum factors it is as well the retained placenta and also the instrumental delivery, prolonged labor. So these odds ratios, as shown in the previous 2 slides, are no more than a textbook pre-delivery likelihood ratio of the risk that a woman will have a postpartum hemorrhage. But most importantly, we should always be prepared, because even a woman without any risk factors can suddenly start bleeding profusely. So the most important part is that we always should be prepared, not only as an individual but also as a team, and be very vigilant. What can we do to reduce the risk, the likelihood of a PPH to occur? Sometimes that's described as prevention, but prevention would mean you could completely reduce the risk to 0, and that's not the case. The most important part here is through active management of the 3rd stage of the delivery. I discussed that already somewhat in the labor and delivery video part 2, as you can see here. You can see the direct link. What does active management mean? Firstly, we administer a uterotonic drug of choice, and if there's IV access, that will be 10 international units of syntocinon, or if not available, it could be given intramuscularly. Then cord clamping. Usually it's the evidence now tells us it's okay to wait for 1 minute, because that improves the fetal hemoglobin without any side effects. Controlled cord traction with one hand, whilst the other hand keeps the uterus at bay. And here are a few pictures. Here we can see that the left hand supports the uterus and the right hand puts traction on the umbilical cord, and we can see already here that the placenta is appearing. Important that we only do this when the uterus is well contracted, because if not, it could result in uterine inversion. So apply firm traction to the umbilical cord with one hand, firm if it's a term placenta, but be careful if you're dealing with a small preterm placenta. Here we see a diagram from another source where they advocate to apply suprapubic counterpressure with one hand to prevent a uterine inversion. So important that the uterus is well contracted. With one hand we gently pull downwards from at the level of the umbilical cord, and the other hand we keep to prevent the uterus from descending. Active management versus expectant management for women in the 3rd part of labor. I'm referring here to the Cochrane database systematic review, most recently updated in March 2015, and it shows clearly when we offer active management compared to expectant management that there is a significant decreased risk of PPH more than 1 liter. This forest plot shows, the top part shows 4 studies from high income countries, as you can see here. Here, the low income settings, we have no reliable studies. So it's good to know that the findings of these studies are derived from high, well-resourced countries. And eventually what happens, what are our findings? We can reduce the likelihood, the relative risk of PPH to occur by 62%. And it's good to realize that the absolute risk is reduced from 2.4% to 0.9%. So good to discern between relative and absolute risk. So this is not only applicable to blood loss from more than 1 liter, and we have the same finding, unsurprisingly, if we would use the need for blood transfusion as an outcome measure. Here we see the relative risk is reduced by 65% significantly, and the absolute risk is reduced from 2.1 to 1%. So clearly, if you want to minimize massive blood loss or the need for blood transfusion, active management of the 3rd stage is recommended. Other drugs, misoprostol, a randomized clinical trial which compared routine intravenous oxytocin with misoprostol or without misoprostol. And in this randomized clinical trial, no differences were found in PPH rates. The PPH rates was 8.4% in the misoprostol group and 8.3% in the placebo group. And PPH here was defined as blood loss of more than 500 milliliters. Of note is that the women who had misoprostol, 400 micrograms orally, had significantly more side effects, and one of them is fever, and the other one is shivering. And fever is quite confusing, because before you know, we start worrying about intrauterine infection or endomyometritis, and we might want to start antibiotics, whilst it's a side effect of the prostaglandins administered. So misoprostol has no beneficial effect in addition to syntocinon. Side effects of uterotonics: syntocinon, also known in North America, Python S or Pitocin, has minimal side effects, and that's understandable because it's the natural oxytocin which we administer. Ergometrin is the drug with the most well-known side effects. It has a pressure effect on blood vessels, so the blood pressure will go up. Hence we have to be very careful if women are known with hypertension or preeclampsia. Those are relative contraindications, but quite clear women have quite often nausea and vomiting and more pain, because these ergot alkaloids result in a continuous contraction of the uterus. So, and that's why they are effective in reducing the likelihood of PPH. Misoprostol has a side effect, as we discussed: diarrhea, abdominal pain, and fever. There was no risk reduction with the administration of tranexamic acid. This is a drug which inhibits the clot breakdown, the thrombolysis, and in cases in trauma patients, nowadays 1 gram of tranexamic acid reduces the bleeding. But here in the PPH setting, we could not find reliable studies to answer this question, whether tranexamic acid would reduce the risk of PPH. So that's still an area of further research. Now, the management of PPH. A beautiful statue by Auguste Rodin, which represents what the French calls so beautifully le penseur, the thinker. And it's wonderful, doctors, that we reflect, we think, we use our grey matter to find what the differential diagnosis is. But here we have to switch to action. and hopefully combined with some gray matter activity. Let's say a lady with PPH and a Partum Haemorrhage, or for instance an ectopic pregnancy, if she is hemodynamically not stable or has for instance an eclamptic fit, loss of consciousness, we have, and whether it's an OSCE exam or in daily practice, we have to move to stop talking a thorough detailed history and start acting, start the resuscitation following, for instance, the DRABC mnemonic. Regardless of the cause, that's important. Woman's safety is paramount, is number one. So, hypovolemic shock, the most simple rule, the rule of thumb is, if you find that the systolic blood pressure is lower than the pulse rate, in principle, you start managing the lady as having hypovolemic shock. Of course, we can have more detailed and refined information, but this is important to keep in mind. What are the clinical signs and symptoms of increasing blood loss? This chart tells us if the woman lost between half a liter and a liter, she still can have a normal blood pressure. The pulse rate will go up. She might tell you that she has palpitations or symptoms of dizziness. First sign of blood loss. If the blood loss now increases and then is now between a liter and a half, hypertension, systolic blood pressure between 90 and 80, tachycardia, and tachypnea starts to kick in. Skin is pale, she starts sweating, and she feels weak, faint, and tells you that she is thirsty. So symptoms of more blood loss. If the blood loss increases with another 500 mils, the hypertension is now more profound and the pulse is rapid and weak. And here it's obvious that the simple rule, the rule of thumb, is applicable. Heart rate goes up, the skin becomes cold and clammy, and there is a poor urinary output, less than 30 milliliters per hour. And the patient sometimes has symptoms of restlessness, anxiety, and confusion. And if you're not familiar with the symptom, you think that you're dealing with a psychiatric condition. No, it's a sign of brain hypoxia. So the brain starts responding in a particular way. If the blood loss is now between 2 and 300,000 milliliters, so then we have all the symptoms. The blood pressure systolically drops further, the pulse increases further and is rapid and weak. The patient suffers from air hunger and there's a complete anuria. The patient is confused, drowsy, or even unconscious. So we have clear-cut, different signs of symptoms depending on the amount of blood loss. So if you observe the fourth part, then you're really behind the 8 ball and you will be competing with death. So it's time for action. And the action should be based on systematic approach. Firstly, so regardless of the cause, firstly, you call for help. Always call for help. More people have this clearly proven that team approach, we as a team perform better as individuals. Start resuscitation. The official mnemonic is danger, responsiveness, airway, breathing, and circulation. And in obstetrics, where we're dealing with usually young and fit women, the focus point of the obstetrician is usually the C of circulation. So the most important part for us is, because the D, the R, the A, and the B are usually not a problem, that is, we want to insert 2 large bore IV cannulas, so we have access. We can give immediate fluid replacement, replace the blood volume loss immediately with crystalloids, and replace it quickly under pressure, or elevate the bag to a higher level. So having IV access can make the difference between life and death. So when you wait and delay, you will have collapsed vessels, and establishing IV access is difficult. So it's the most important part to start straight away. Usually I combine that with rubbing up the uterus and administer an IV oxytocic. By the way, when we insert an IV drip, we take some blood for group and hold, and we prepare ourselves, if need be, to give her a blood transfusion as well. If possible, if you took the first measures, it's very useful to insert an indwelling Foley catheter. Here you can see a diagram where the Foley catheter is inside you. The balloon ensures that the catheter stays within the bladder. Here we see the different parts of the Foley catheter. The balloon port, this is where we connect the urine bag to, and here we see the area where the balloon is deflated and here is inflated. Two reasons to insert an indwelling catheter. One, the urinary output is a simple measure and represents the intravascular volume. So if you're dealing with shock and you still see urinary output for more than 30 milliliters, you know that you are winning and that you're not running the risk that she has, for instance, acute renal failure. So simple to do. And the second reason is a full bladder might contribute to bladder overstretch to uterine atony via the parasympathetic nerve system. So important here that whilst we want to give her, replace the IV fluids, don't do a knee-jerk response where you overfill. Acute pulmonary edema takes place quite often in obstetrics because we administer too much fluid. And usually because the women are healthy and fit, they can cope with that. But it's important that you commence a fluid balance, that you make sure that you only replace the fluid volume lost and no more than that. This concludes PPH part 2. Bear with me, or maybe I should say dog with me. Part 2 will give you all the specifics of how to deal with PPH specifically, and we will discuss the so-called 4 T's. Thank you for your attention for part 2 and looking forward seeing you again when you start part 2. Thank you.